terms of management, so some of these may get better over time, some may not. Okay, so not always, not always. What happens when they don't get better over time? For EPS, one thing I want to highlight, it's always been said to use anticholinergics, particularly antimuscarinic agents. There are three of them, right? We learned this in ANS. Benztropine, triphexyphenidyl, and Biperiden. If you're in the UK, add procyclidine to that, I guess. But do we have all of those four in the Philippines? We don't. We only have one. And that one also happens to be the Medicine Access Program, Biperiden. So you know what? For practice, for the boards or for major exams, I guess, sure, study those. But in actual practice, it's only Biperiden. Just remember Biperiden. Okay? Diphenhydramine can also be used because it does have antimuscarinic properties, and it's also in the Medicine Access Program. So great, right? So we have two options. But take note, why are they only for the two EPS? Why are Biperiden and Difen only listed for dystonia and pseudoparkinsonism? Because those are the only two extrapyramidal symptoms they work for. These two do not work for akathisia. So while akathisia has been shown to be something from D2 receptor antagonists, it seems that the way it works is slightly different in that antimuscarinics do not work. There was a Cochrane review that concluded Biperiden is basically inefficacious for akathisia. So don't bother. Okay, if it's akathisia, there are other drugs that have been tested, like propranolol and some benzos, but nothing promising generally for akathisia. That's another thing that sucks for it. It's very difficult to manage if it doesn't go away. So usually the strategies would be like to lower the dose or switch, unfortunately. And it's difficult to switch if the drug already works for you. Now, tardive dyskinesia, usually, if that starts happening, you really start considering reducing the dose or switching, because it can be very problematic. I mean, there are some options being tested, but again, nothing really super promising about it. Okay, now for ham stuff, particularly the M in ham. Some of these are pretty intuitive once you hear about them, so I won't explain them too much, but I will just give some disclaimers. Particularly, let's start with dry mouth. You know, dry mouth sounds like not as bad as EPS until I also only realized this recently. Dry mouth, if you leave it at that for a long time, this can be a risk factor for tooth decay. Yep. So it's not as bad as it seems. Talk to someone who's had tooth decay, root canals, and all of that. Not pleasant, pain-wise, wallet, bank account-wise, not pleasant at all. So take it seriously, all the same. Some tips, when you talk about adding moisture back to your mouth, don't overdo it. Because remember, saliva is not just water. There are lots of other things there. And with a dry mouth, yeah, the moisture is gone, but you still have the other stuff that is there as a thin film. And if you keep drinking water too much for a dry mouth, that remaining film of mucin might be washed away. That will just make your tongue and your mouth more prone to injury. So, what else? Chewing gum can help possibly stimulate saliva secretion. Avoid things that help dry the mouth more. Yeah, the usual stuff, the vices. Coffee. And ano pa? Humidifier. That's a bit pricey perhaps, depending Pero another thing. This one is a more recent edition. This was based on a dentistry review, actually. I was surprised. Edible oil. Just a few drops of edible oil can help perhaps coat the mouth, mucosal surfaces, and prevent injury related to dry mouth, at least. Okay? Constipation, standard trio, of course. Hydration, exercise, fibers. But the fibers is conditional. If the constipation is from clozapine, please do not use fibers. I'll talk about that later, but this is a reminder that the fiber bit is not universal. Hydration is absolutely necessary. Exercise will help, but the fiber is contingent on what type of drug we're talking about here. If it's clozapine specifically, do not use fiber. And if you use fiber, it should always be paired with water, okay? It will not work without the water. So always pair the fiber with water. And again, if it's clozapine, do not use fiber, okay? Now, for incontinence, difficulty urinating because of antimuscarinic action, Of course, maybe don't probably have to recommend avoiding fluid intake near bedtime, practical stuff, and try to completely void the urinary bladder, empty it before bed. Try, of course. Orthostatic hypotension, the usual advice, right? Stand up slowly from a sitting position, hydration. The rest, of course, gotta monitor these with the clinical team and all of that. Now, at this one, NMS. NMS is an emergency. This one, especially for these later ones, I had to remove the tolerance developed with time. Because I did not want to give you the impression that NMS is something to take lightly, like, tolerance is developed with time. No. NMS is kind of an emergency. Autonomic dysregulation, increases in body temperature, muscle rigidity, and so on. It's very heterogeneous, so you really gotta put it into context of when is there a D2 receptor blocking agent that was started recently? When was it started, right? What are the symptoms? Are there any other drugs? So on. Yeah. This may overlap with the manifestations of serotonin syndrome, but one thing that makes it distinct is in NMS, it's more of rigidity, like lead pipe rigidity, similar to Parkinson's, whereas with serotonin syndrome, it's more of the sensitivity to reflexes. Even without a reflex hammer, you can stimulate your reflexes, and a sustained clonus, the muscle contraction when you push against, and of course the causative agent. It's an emergency. We have there are options. The evidence is not stellar. It's not stellar. Bromocriptine is in the PNF. Dantrolene is imported, I believe, based on the hospital pharmacist I talked to. So it's a compassionate use drug. These are at least some options.